Hello friends, myself Dr. Vishal, and now we are going to start part 3 of bird's eye view on ECG, and in this part we are going to learn ischemia and infarction. Okay, so now there are basically two types of injury whenever we are considering ischemia. Okay, so in what happens in subendocardial injury, the injury is confined to a limited portion of heart that is near the endocardium. Okay, so what happens in this kind of injury? The current of injury goes from outside to inside. Okay, so current of injury, it goes inside from outside. Okay, so we know from our basics which we have learned in first years of MBBS in physiology. So whenever the current of injury goes from outside to inside, and whenever it goes away from that lead, it would show negative deflection. Okay, so as you can see that this is heart, and in heart this is lateral wall. Okay, and the leads which are facing the lateral wall are V5 and V6. So what happens whenever there is subendocardial injury or subendocardial ischemia which is on the lateral wall of the heart? Okay, and what happens if it is subendocardium? So the vector goes inside from outside. So whenever vector goes inside to outside, the leads which are facing at the lateral wall, for example V5 and V6, it would show negative deflection. That's why it would show ST depression. Okay, so remember this thing, that whenever the current goes away from the lead, it shows negative deflection. The second rule is whenever the current comes towards the lead, it shows positive deflection. Okay, so coming towards the second type, the second one is transmural or epicardial injury. Okay, so what happens in transmural injury? The whole thickness of myocardium is involved. So for example, this whole part is myocardium. Okay, so this whole is involved, and in such kind of injury, the vector comes from inside to outside. As you have seen that, in this kind of injury, vector goes inside from outside, and in this kind of injury, vector comes outside from inside. So the leads which are facing at that this side would show positive deflection. Okay, so if we consider that there is an ischemia, or better to say infarction, in this lateral wall, as we all know that lateral wall is best seen with lead number V5 and V6. Okay, so in V5 and V6, it would show ST elevation. Okay, because the current of injury comes from inside to outside. Okay, now moving to next slide. Okay, so as you can see that there are two types of involvement. Okay, the first one is transmural involvement, the second one is non-transmural involvement, and the third one is endocardial or epicardial involvement. Okay, so the first one, transmural involvement. Now let's see, there is extension through the myocardial wall from the endocardial to epicardial surface. Okay, so as you can see, if this is the heart, this is the heart. Okay, so this whole thickness of the heart is involved. It is transmural infarction. Non-transmural infarction, there is clinical evidence of myocardial damage without consistent ECG changes. Okay, we'll see it further. Okay, so then the third is endocardial or epicardial. What is endocardial or epicardial? It refers to the innermost and outermost surface of the myocardium. So whenever there is endocardial infarction or whenever there is epicardial infarction, you can see that If there is endocardial infarction, the inner part of the heart is affected, and whenever there is epicardial infarction, the outermost part of the heart is affected. Okay, so this is endocardial or epicardial infarction. Now let us see that which are the leads, which are the referral points, which are and what they suggest. Now let us see. Inferior wall of the heart, it is best seen with leads 2, 3 and AVF. Okay, so this is lead number 2, lead number 3 and lead number AVF. Okay, then the anterior wall of the heart is best seen with lead number 1 and lead number AVL. Okay, and the posterior wall of the heart is best seen with lead AVR. Now let us see that whenever we are this we can see in this which is this plane. This is frontal plane. Okay, this frontal axis, and whenever we are going to see the horizontal axis, we are supposed to see this chest lead from V1 to V6. Now let us see. This V1 and V2 are supplying the septal portion of the heart. Okay, V1 and V2 supplies the septal portion of the heart. V1 and V2 supplying septal portion of the heart. V3 and V4 are therefore anterior wall of the heart, and V5 and V6 are therefore lateral wall of the heart, and mirror image of V1 and V2 is therefore posterior wall of the heart, and V3R and V4R is for RVMI, that is for right ventricular wall MI. 2, 3 AVF is for inferior wall of the heart, and 1 and AVL is for high lateral wall of the heart. Okay, now let's move forward. These are the criteria of ischemia. The first criteria is there should be at least one segment of ST depression. Okay, then the second is the symmetrical or deeply inverted T waves. There should be presence of abnormally tall T waves, normalization of abnormal T waves, prolongation of the QT interval, and there can be the presence of arrhythmia, bundle branch blocks, AV blocks, or electrical alternance. Now let us see in this ECG what you can see. So now V1, V2 and V3, it is apparently normal, no any major changes. Okay, so what is there in this lateral leads? You can see this V6, V5 and V4. There is depression of the ST segment. Okay, and note that there is upsloping ST depression is not an ischemic abnormality. Upsloping of ST depression is not an ischemic abnormality. So these are the DDs of ST depression. The first one is digitalis effect. The second is hypokalemia. The third one is LVH with strain pattern. The fourth one is RVH with strain pattern. The fifth one is non-ST elevation myocardial infarction. Then the sixth one is mitral valve prolapse, or we can say Balu syndrome. This is CNS disease, for example, raised ACT in cases of SAH. Okay, subarachnoid hemorrhage. And then secondary ST changes with IV conduction, IVCD, like IV conduction block, for example, right bundle branch block, left bundle branch block, and Wolff-Parkinson-Walsh syndrome, that is WPW syndrome. So now let us see what are the differentials of ST segment depression. So it can be either normal variant or it can be artifact. Okay, This pseudo ST depression, it can be because of wandering baseline due to pure skin to electrode contact. There can be physiological J-junctional depression with sinus tachycardia, and it is most likely due to electric repolarization. Okay, and there can be because of hyperventilation induced atria segment depression. You can see this is a wandering baseline. It can be because of poor contact with electrode whenever the technician or nursing staff, whosoever is taking the ECG, if he or she has not applied proper gel, then it can be seen. Okay, now these are the criteria for infarction. Okay, so whatever we had seen criteria, it were the criteria of ischemia, and these are the criteria of infarction. So what is considered as significant ST elevation? So greater than 1 millimeter of elevation in greater than or equal to 2 contiguous limb leads. For example, 1, 2, 3, AVR, AVL and AVF. If there is ST elevation of greater than 1 small box in height, it is considered as significant ST elevation in limb leads, which should be contiguous. And the second thing is there should be greater than 2 mm of ST elevation in contiguous chest lead, that is V1, V2, V3, V4, V5 and V6. Now, the second thing which you must know, what is significant Q wave, or what are the criteria to signify whether this is significant Q wave or not. So whenever you find a Q wave in an ECG, first of all you are supposed to check the depth of Q wave. So whenever the height of Q wave, it is equal to or greater than 25% of or 1/4 of the QRS or the QRS height, or it is greater than 1/4 of R wave height, then it is considered to be abnormal or significant Q wave. Okay, so whenever this Q wave is not considered significant in AVR, in lead number 3 or V1 alone, and in V1 to V3 if it is associated with left bundle branch block. Remember this point, if it is associated with left bundle branch block, V1 to V3, Q wave is not considered significant, and it is considered pathologic if it is greater than or equal to 0.04 seconds of duration. Okay, so whenever it is broader than 1 small box of ECG, it is considered as pathological, and if it is greater than 25% of the height of R wave. So as I told you, is 1, 2, 3, 4. Okay, and this is 1. It is greater than 1. So whenever the Q wave is greater than the 25%, this is 4 and this is 1. Whenever this is greater than 1/4 of the R wave, then it is considered as significant, or this is broader than this 1 small square. As I told you that if it is broader than 1 small square, it is considered as significant. Now let us see what is the timing of myocardial infarction. As we have learned in our basics in second year and third year MBBS, the criteria for considering whether this myocardial infarction, if it is or if it was present, it can be very well picked up from ECG paper. Okay, so ECG, on an ECG you are supposed to check first of all ST segment. The second thing you are supposed to check is T wave, and the third thing you are supposed to check is Q wave. Now let us see one by one what is the significance of all these 3 points in an ECG to consider whether this myocardial infarction is whether it is acute, hyperacute, recent, or undetermined age and old. So what is hyperacute MI? Hyperacute MI, whenever MI occurs in first 6 hours, it is known as hyperacute MI. There can be presence or absence of ST segment elevation. There are T waves which are picked and Q waves are absent. Remember that whenever there is an acute hyperacute myocardial infarction, always there is absence of Q wave. And ST elevation, either it can be normal or it is elevated. The second thing is acute myocardial infarction. If it is occurring between 6 to 24 hours, then it is acute myocardial infarction. ST elevation is very significant. Q waves, they can be present, they can be absent, and T wave is plus minus. Then what is recent MI? Recent MI is the presence of Q wave in most of the ECG, in 3/4 of the ECG of transmural infarction, and ST elevation is almost always present, and the T waves are inverted. It is seen from first 24 hours to 72 hours. So within after the end of first day to the end of third day. And what is undetermined age? So whenever there is a prominence of Q wave, there is ST elevation absence, and T waves are inverted. So it can be anywhere between 3 days to 6 weeks. Okay, so it can be between 3 days to 1.5 months, 72 hours to 6 months. And when you can label that this is an old MI, so there is prominence of Q waves, there is absence of ST segment elevation, and the T waves are upright. Remember that T waves are upright whenever there is ST segment is normal, Q waves are prominent, and T waves is upright. So it is greater than 6 weeks. So now let us see what is the evolution of acute MI. This is a normal ECG. This is an hyperacute. This is a hyperacute. This is evolving or acute. This is recent or resolving. This is undetermined, and this is old. As I told you in the previous slide, normal ECG, everything is normal. Okay, there is no Q wave. There is ST segment which is isoelectric, and T wave is almost normal. Okay, so what is hyperacute ST elevation MI? There is prominence of T wave, there is slight elevation of ST segment, and Q wave is absent. T wave changes increase T wave amplitude and width. May also see ST segment elevation, and in this we can see this evolving MI. There is marked ST segment elevation. And what is the criteria for significant ST elevation? Okay, so greater than 2 mm height of ST segment in chest lead, that is V1 to V6, and greater than 1 mm of height of ST segment in lead 1, 2, 3, and AVR, AVL, and AVF, that is limb lead. So this evolving MI is marked ST segment elevation with hyperacute T wave changes. It is because mostly of the times, or almost all the times, it is because of transmural injury. So this D is recent or resolving MI. How we can say that it is resolving? It is going to show the presence of Q wave. Okay, then it is showing the T wave inversion, and the ST segment has started to decrease in height. So there is pathological Q wave, there is less ST segment elevation, and there is terminal T wave, and there is inversion of T wave, which is showing necrosis of the myocardium. This is in this diagram. You can see there is undetermined or healing kind of myocardial infarction. In this, you can see there is pathological Q wave, ST segment is going to be normalized, and there is deep T wave inversion because of necrosis and fibrosis. So whenever there is old MI, there is the presence of Q wave, ST segment has normalized, and T wave inversion, which was there previously, it has settled down. Okay, so now let's move to next slide. So these are the DD of ST elevation. It can be because of acute MI, it can be because of acute pericarditis, it can be because of VRP, that is early repolarization syndrome. Then it can be because of ventricular aneurysm, it can be because of severe LV wall hypokinesia, and it can be because of Prinzmetal's angina or variants angina. So now let us learn what are the differentials of ST segment elevation. For example, the first and most important is ischemic heart disease. So whenever there is ischemic heart disease and there is the ST elevation which is convex upwards or straightened, it can be because of acute transmural injury, as we can see in acute myocardial infarction. Persistent ST elevation after acute MI shows ventricular aneurysm, and it is known as ventricular aneurysm pattern. And this ST elevation may also be seen as a manifestation of Prinzmetal's or variants angina, and ST elevation during exercise test suggests there is extremely tight coronary artery stenosis or spasm, that is because of transmural ischemia. And the second very close DD of acute myocardial infarction and myocardial ischemia is acute pericarditis, as we have seen that in this ischemic heart disease the ST segment was convex upwards, and this in acute pericarditis you can see that there is the concavity upwards. It was convexity in the MI, and there is concavity upwards in ST segment elevation in most of the leads except AVR. This now let us remember this differential, very close differential of each other, that is acute pericarditis and acute myocardial infarction. What happens in acute myocardial infarction? There is ST segment elevation, and what happens in acute pericarditis? There is ST segment elevation. So what is the basic difference? In acute pericarditis, there is ST segment elevation in all the leads except AVR. Except AVR, there is ST segment elevation in rest of the 11 leads. And what happens in an acute myocardial infarction? There is ST segment elevation of the leads which are towards the direction of the vector, and there is the reciprocal change in the corresponding leads. So for example, if there is infarction of the anterior valve, there should be ST elevation in the leads which are facing the anterior wall of the heart, and there should be ST segment depression. For example, ST segment depression or reciprocal changes in lead number 2, 3 and AVF. You can see that there should be ST elevation in some leads and there should be ST depression in the reciprocal leads. And this such thing does not happen in acute pericarditis. There is the presence of concavity upwards in ST segment elevation in most the leads except AVR. Now let us see, I have made a funny illustration. So whenever you have found a patient in the emergency or casualty at the middle of the night, he is suffering from a very severe chest pain, you see tall ST segment elevation, and in the most lead you get frightened up. So you have to, if that is specifically a young boy, for example a 16 to 18-year boy, he has chest pain and you see ST segment elevation of this kind, you need not to be worried, because this kind of ST elevation of concavity upwards, this is concavity upwards, it is because of acute pericarditis and it is not because of acute myocardial infarction. And if a 60-year-old or 80-year-old gentleman comes to casualty in the middle of the night or in the early morning, you see tall ST segment elevation of this concavity upwards, you need to be very cautious. Okay, so this for acute pericarditis, you need not to be worried and you have to be very cautious. This is for acute myocardial infarction. Remember this, you will never forget in your whole life. So there is no reciprocal ST segment depression except in AVR, and unlike in early polarization, the T waves are usually of low amplitude and heart rate is usually increased, and you can see PR segment depression, a manifestation of arterial injury. And there is a must to remember point, that is there should be ST segment elevation along with the depression of PR segment in acute pericarditis. Now I think you have got your picture clear. So this is the third DD for ST segment elevation that is normally seen in many of the patients, which is because of early repolarization. This is usually concavity upwards ending with symmetrical large and upright T waves. There is the high takeoff of the ST segment in lateral leads only, lead V4 and V6. ST elevation V2 and V3 is generally seen in most of the normal ECG, and the ST segment elevation V2 to V6 is concavity upwards. Concavity upwards. Concavity, not convexity. So these are the other causes, for example in LVH, in right precordial leads with large S wave, in left blunder branch block, same with right precordial leads with large S waves. It can be seen in advanced hyperkalemia and it can be seen in hypothermia, prominence, Osborne or J waves. Now let us see some examples of myocardial infarctions ECG. Now in this slides we are going to see the anteroseptal myocardial infarction. It is involving the anterior wall and it is involving the septal wall. So whenever the septum is involved, it shows changes of ST segment elevation in leads number V1 and V2, and if it is involving anterior side of the heart, it shows the ST segment elevation in V3 and V4. Okay, so there should be ST segment elevation in V1, V2, V3 plus or minus V4. Okay, so now let us see that there is deep Q wave, QS, deep QS, deep QS. Okay, there is ST segment elevation, baseline almost 3 mm from here, and in V4 you can see there is very minimal, or you can say almost nil ST segment elevation, and here you can see there is T wave inversion lead number V4 and V5. So now let us see what is that. There is Q, QS or small q, small r, capital S complexes in lead number V2, V1, V2, V3 and sometimes the V4. There is evolving STT changes, and for example in that ECG sleep that we had seen, that there was fully evolved interoceptal myocardial infarction because there was the presence of Q and Q waves, so it was evolved QS waves in lead number V1 and V2, and small q, small r and S complexes in lead number V3 plus STT changes. You can see there are STT changes, ST elevation, T inversion, T inversion, T inversion, T inversion, and ST segment elevation, T inversion, ST segment elevation, T wave inversion. So what happens in anterior MI? There is almost similar changes, but V1 is spared because V1 is little bit of right side of the heart, so V1 is spared. And if V4 to V6 is involved, it is called as anterolateral because V5 and V6 are the leads which are facing towards the lateral side of the heart. For example, acute anterior or acute anterolateral myocardial infarction. Now let us see in this example. What you can see, there is very significant ST segment elevation. It V2, lead number V3, there is ST segment elevation. Then there is in V4, V5 and V6. So now please pay attention to this electrocardiogram. Now let us have a look at this V1, V2, V3, V4, V5 and V6. This all the chest leads. You can see that V1, V2 and V3 are apparently looking normal, right? And then what is there in inferior leads? Lead number V, lead number 2, lead number 3 and lead number AVF, and another limb leads 1 AVL and AVR. As you can see, there is a bit of ST segment elevation and lead number AVL. If you can appreciate, there is a bit of ST segment elevation in lead number 1 and AVL, which is suggesting of lateral wall myocardial infarction. So what happens in MI with bundle branch block? It can be seen as MI with right bundle branch block or MI with left bundle branch block. For considering whether there is an MI with right bundle branch block or left bundle branch block, specifically left bundle branch block, we are supposed to apply Garbosa's criteria, which is beyond the scope of this discussion. Now let us have a look what is seen in this ECG. You can see that in this leads V1, V2, V3, V4, V5 and V6, you can see that it's small r, S and another r. This R dash or rabbit ear pattern in these leads in the anti-HS lead, which is suggesting of, and there is this M pattern, this is suggesting of right bundle branch block pattern. And what are the other abnormalities? As you can see, there is ST segment elevation in lead number 3, bit of in lead number 2, and another elevation you can't appreciate this in AVF. So what you can see is inferior wall MI because of the ST segment elevation 2, 3 and AVF associated with bundle branch block of right side, that is right bundle branch block.